So hello everyone, on behalf of EuroELSO, it's a special pleasure to welcome you to today's EuroELSO webinar on veno-arterial ECMO and septic shock. My name is Peter Schelongowski from Vienna, Austria. I will be moderating the webinar, and it's a very special pleasure to welcome today Nicolas Bréchot, who is the expert in the field of VA ECMO and septic shock, and he has a lot of exciting data to share with us in this potentially even underutilized therapeutic mode in extracorporeal circulation. Nicolas, thank you so much for being with you. We're looking forward to your presentation and for the succeeding discussion.
Thank you very much, Peter. Thank you very much for this invitation. I'm really happy to be with you today discussing about VA ECMO in septic shock. So as you may know, I moved recently from La Pitié-Salpêtrière. I've been working for more than 10 years with Professor Combs in La Pitié-Salpêtrière, and I moved recently to another hospital in Paris, the European Georges Pompidou Hospital, and we have also a circulatory assistance program there. I don't have any conflict of interest with the talk, so reversible myocardial dysfunction during sepsis. This is something we know. It has been described a long time ago during the 80s, at the beginning, mostly depending on Margaret Parker's team, who noticed in our cohorts of patients that they had a transient decrease in their myocardial function and cardiac index, associated with an increase in systemic vascular resistances and returning back to normal after several days. We are several decades after those first observations, and we still have many questions regarding this pathology. In fact, the causes of this myocardial dysfunction are still imperfectly understood. The main hypothesis is that it may be due to the cytokine storm we have during sepsis, and there are data supporting that. Here you can see work performed also during the 80s, a study during which authors were able to isolate myocardial cells and record their spontaneous contraction ex vivo, and they observed that while incubating those cells with the serum of patients affected with septic shock, they had a clear decrease in the spontaneous contractions of the cells. And that was not the case with control sera or even with serum of patients recovering from septic shock. So from those observations, they described what they called a circulating myocardial depressant substance. And during the past decades, many teams have been trying to isolate the substance responsible for that. In fact, they could reproduce those results with a lot of substances linked to inflammation, like endotoxin, TNF-alpha, IL-1 beta, IL-6, nitric oxide. So again, the idea is that probably the cytokine storm we have during sepsis is responsible for this reversible myocardial dysfunction. Catecholamines also may play a role, at least for a part of those patients. We have to use high doses of catecholamines in septic shock patients, and we know that this can induce a myocardial stunning, what we call a catecholergic cardiomyopathy. And this is probably also responsible for at least a part of the severe myocardial dysfunctions we observe in our septic shock patients. Other questions, the incidence of this myocardial dysfunction. For a long time, people were thinking that, in fact, a mild myocardial dysfunction was quite common during septic shock, but that severe myocardial dysfunction was extremely rare. And in fact, more and more in recent studies, we are realizing that this is not that uncommon. Of course, severe myocardial dysfunctions is not the most common hemodynamic profile. The most common hemodynamic profile is, as you know, vasoplegia with a preserved cardiac index, at least. But apart from this most common hemodynamic profile, we have in fact a significant proportion of patients developing a completely distinct hemodynamic profile consisting in severe myocardial dysfunction. And you will see that it's probably around 10–15% of the patients, so not that exceptional. And that was already noticed by Margaret Parker, in fact, during the 80s. And you have here an example of that. She described in that study that half of the non-survivors were in fact dying with an extremely severe myocardial dysfunction, what she called a cardiogenic shock-like state. We call it now a sepsis-induced cardiogenic shock. Other question remaining, the impact of this sepsis-induced cardiogenic shock. And you will see that we have recent data showing that it's associated with an extremely poor prognosis. Patients with severe sepsis-induced cardiogenic shock have around 80% mortality, globally the same as severe cardiogenic shock, in fact. So this is one of those studies published by a French team. They were able here to depict several key parameters reflecting the hemodynamic status of the patients in a multi-center cohort of septic shock patients. They had the variations of the SVC reflecting the volemia of the patients. They had the left ventricular ejection fraction and aortic VTI reflecting myocardial function and cardiac output. And they had also the diastolic arterial pressure reflecting the level of vasoplasia. And from those parameters, they made a principal component component analysis, so a statistical analysis, trying to define clusters of parameters working together. And from this analysis, they isolated 5 hemodynamic profiles. And what is interesting, in fact, is that those hemodynamic profiles are consistent with those we observe during our daily practice. So in orange, in blue, you have compensated patients. In orange, you have patients with those hyperdynamic states with extremely high cardiac index. In purple, you have those patients with extremely severe vasoplasia with very low diastolic arterial pressure. And in green, you have patients suffering mostly from severe vascular leakage and severe hypovolemia reflected by high variations of the SVC. So those 3 profiles reflecting vasoplasia and vascular leakage are the majority, represent the majority of the patients. But apart from those profiles, we have another one in red, consisting in patients with significant myocardial dysfunction and reduced cardiac output compared to the other profiles. And you see that this profile is not exceptional. It's 17% of the patients here. And it's the cluster associated with the highest ICU mortality. Even in fact, if patients had here a wide range of severity. So this is not that uncommon and it seems to be really severe. This is confirmed in other studies. This is an old one in patients receiving high doses of vasopressors. What is interesting for us is that here they had 6 patients with severe myocardial dysfunction. They almost all died. Here, this is a study conducted in children. The purpose of the study was to define parameters associated with refractory septic shock in children. So they asked first experts what were for them parameters reflecting the severity of the shock. And they made several rounds, but finally they returned 3 parameters: hyperlactatemia above 8 or increasing during the first hours of resuscitation, high doses of catecholamines received by the patients with an inotrope score above 200. So the inotrope score is a way to evaluate the cocktail of catecholamines received by the patients, and you have the formula here. It's the epinephrine dose plus norepinephrine dose multiplied by 100 plus milrinone dose multiplied by 20 plus vasopressin dose multiplied by 10 plus dobutamine dose. So 200 mics, it's more or less 6 milligrams per hour in a standard patient. And severe myocardial dysfunction also was associated for the experts with a poor evolution, defined here by a left ventricular ejection fraction below 25 and a cardiac index below 2.2. So they analyzed the statistical link between those parameters and the outcome of the patients in a validation cohort, and they found that both 3 parameters were independently associated with the mortality, and myocardial dysfunction was strongly associated with the poor outcome. From those statistical associations, they built a score. They called it the bedside septic shock score, and they analyzed how the score was able to predict mortality in another multi-center cohort. And the score was well predicting mortality. And what is interesting for us is that as soon as you had a severe myocardial dysfunction and receiving significant doses of catecholamines or exhibiting severe hyperlactatemia, the mortality was extremely high, above 80%, confirming that this hemodynamic profile is extremely severe. This is the last study I will show you, a study coming from another French team in Nancy, in patients suffering from septic shock and receiving high doses of vasopressors. Here they had 16 patients over 106 exhibiting a sepsis-induced cardiogenic shock, defined here by a left ventricular ejection fraction below 35 and a cardiac index below 3. So again, this is not exceptional, in fact, this hemodynamic profile. It's not the most common, but we are probably at around 10–15% of severe patients. And mortality was extremely high also, more than 80%. So in those patients with severe myocardial dysfunction and a very poor outcome, there is a strong rationale for using VA ECMO as a rescue therapy. In fact, the first data on that topic came from pediatric studies, and particularly with 2 studies published by McLaren's group. The first one in 45 patients suffering from refractory septic shock, and the second one in 23, and they described they had good results, even with an end-stage rescue therapy here. In the first study, there was, as I can remember, there were 40% of the patients implanted under CPR. So they were really dealing with rescue therapy. And despite that, they had good results in terms of survival, 50% long-term survival in the first cohort and 74% in the second cohort. So after those studies, and it's been a long time, in fact, pediatric guidelines are recommending considering implanting a VA in children suffering from refractory septic shock, so refractory to all the standard treatments. In adults, the first results were more equivocal. And you have here one of the first cohort studies describing patients rescued with VA in the context of refractory septic shock. They had 52 patients here, a study coming from Taiwan. The survival was very poor, 15%. But in fact, if you look at the hemodynamic profile of the patient, at least the data we have reflecting that hemodynamic profile, patients had a preserved left ventricular ejection fraction, meaning that they were probably dealing mostly here with refractory vasoplasia. And the rationale for using VA in that context is less clear, obviously, than patients with severe myocardial dysfunction. And accordingly, they only could reach low blood flows in that study, 2.6 liters mainly. For quite long period of time, this study was the largest one. 71 patients rescued with VA during refractory septic shock, coming from Korea this time. Results were very poor. This is the blue line with a survival rate below 20, clearly less than standard cardiogenic shock patient. But here again, they did not select the patients on their hemodynamic profile. So they were mostly dealing, probably, with the most common hemodynamic profile, meaning vasoplasia. In our center in La Pitié, we had been led to implant VA as rescue therapy in patients with extremely severe myocardial dysfunction and reduced cardiac index during septic shock. Really, as rescue therapy, we had all the facilities for that, our mobile ECMO trivalting running, so we tried. And we had the feeling we had good results. And we made the first point in 2013. At that time, we had 14 patients assisted for that purpose. And that was a surprise for us because we were really dealing with end-stage rescue therapy for those patients. But finally, we had 10 over 14 long-term survivors, patients who could recover rapidly from their myocardial dysfunction that completely normalized during the follow-up for the survivors, and patients who could survive with good quality of life. So we wanted to have a better view on this effect of ECMO during sepsis-induced cardiogenic shock. We conducted a large multi-center collaborative trial that was published in the Lancet 2 years ago. So in that trial, we recovered the charts of patients assisted for that purpose of sepsis-induced cardiogenic shock, coming from 5 ECMO centers, La Pitié-Salpêtrière in Paris, 3 other centers in France, and Daniel Brody's team in New York. And of course, patients assisted with the preserved left ventricular ejection fraction were excluded, and we put the cutoff defining severe myocardial dysfunction as left ventricular ejection fraction below 35% and cardiac index below 3 liters per minute per meter square. We had 82 patients assisted for that purpose. We were really dealing with rescue therapy with those patients. As you see here, they had an extremely severe myocardial function with a pre-inclusion cardiac index at 1.5, left ventricular ejection fraction at 17%. They were receiving very high doses of catecholamines, reflected by an anotrope score of 279, meaning more or less 8 milligrams per hour of norepinephrine. They had severe lactic acidosis. They had received a lot of fluids before rescue therapy, and they had already an installed multiple organ failure with high SOFA and SAPS-2 score. You can see also that the rescue occurred quite shortly during the time course of the disease. We were at around 24 hours after the beginning of the shock. So regarding the study we saw previously, we had with those patients predicted mortality that was extremely high, more than 80%. And finally, we had here 60% survival. So it seems that ECMO could completely reverse the prognosis of those patients in that study. To have a better view on that, we needed patients who did not receive ECMO with this kind of hemodynamic profile. For that, we took 3 large septic shock databases. The septic shock, the database coming from the SepsisPAM trial. So I don't know if you remember, the SepsisPAM trial was conducted by a French team coming from another town in Angers. And it was a multi-center randomized trial testing 2 levels of mean arterial pressure during sepsis. The study was negative. So we had that database available. We took also a second database coming from the same center and the third database coming from Nancy, the one we saw previously, 106 patients receiving high doses of catecholamines during septic shock. From those databases, finally, with a little bit less than 1,000 patients, we isolated patients with severe myocardial dysfunction with the same definition as for VECMO patients, meaning left ventricular ejection fraction below 35 and cardiac index below 3. And then we took patients with sepsis-induced cardiogenic shock. So for that, it was the combination of severe myocardial dysfunction and significant doses of catecholamines received with a 9-OTROP score above 75 and significant hyperlactatemia, the lactatemia above 4. So the 3 criteria were defining the sepsis-induced cardiogenic shock for that control group. And the first major result was that we could confirm here that, in fact, it's not that uncommon. We were also around 10-15%. Here it was 13% in this large database of 1,000 patients. So again, this is not exceptional. You have here those control patients. They were less severe at the time of inclusion, meaning when they presented this sepsis-induced cardiogenic shock. They had a cardiac index at 2.2, a left ventricular ejection fraction at 28. They were receiving less catecholamines than ECMO patients. They had less pronounced hyperlactatemia, less pronounced multiple organ failure. They had also, of course, some differences regarding their demographic data. We are dealing with retrospective data. They were a little bit older, and they had some differences in the site of infection. But globally, they were less severe. And what were their, what about the outcome? We confirmed also extremely poor outcome for those patients with this hemodynamic profile, 25% survival at 90 days. So dealing with retrospective data, we always have, of course, some differences between groups, and to better isolate the effect of ECMO in that study, we weighted the patients on their propensity score of dying. So there are several ways to do. You can match the patients on their severity, but doing that, you lose a part of your patients. And here it was a weighting. So patients were pondered on their propensity score. So we took in that study all the parameters associated with mortality, meaning the age, and they appear in green in that table, the age, the immunocompromised status, the delay between shock and inclusion, the level of circulatory failure with the pre-inclusion cardiac index, the catecholamine received, the blood lactate, the fluids received before inclusion, and the level of multiple organ failure with the SOFA score. And from those parameters, we built for each patient a propensity score, and we weighted the patients on this propensity score. Doing that, we had populations that were comparable in terms of age, in terms of severity and multiple organ failure. We had some differences persisting in the source of infection. We had more pneumonia in the ECMO group doing that, but we made several sensitivity analyses to be sure it was not interfering with the results. And finally, we still had, even in waiting those patients, we still had a huge effect of ECMO with a survival climbing from less than 20% in non-ECMO patients, this is the blue line, to around 60% in ECMO-assisted patients, this is the red line. We had also a faster decrease of catecholamines in the ECMO group in red here than the non-ECMO group in blue, and a better clearance of lactates, as you can see here. And we had, as we observed in our first study, a rapid recovery of the heart of the patients. They had a huge myocardial dysfunction at the time of rescue therapy, and they recovered quickly to normalize during the follow-up in the ECMO group. So this is one of those patients, Mrs. Yu. When we called for, she was 52 years old. She had no previous medical condition, and she had been admitted in a small hospital 60 kilometers far from Paris for a septic shock due to an E. coli pyelonephritis. She had a ureteral drainage. Of course, she received antibiotics and fluid therapy, but despite that, she developed an extremely severe septic shock with this very particular hemodynamic profile of sepsis-induced cardiogenic shock. When we are called for, she was receiving epinephrine at 5 milligrams per hour. She was mechanically ventilated. She had a huge myocardial dysfunction with a left ventricular ejection fraction at 20%, a cardiac index at 1.5. You can see the very low pulse pressure. She had a severe tachycardia, severe hyperlactatemia. She was receiving renal replacement therapy. She had huge coagulation disorders. And finally, severe multiple organ failure reflected by a SAPS-2 score that was extremely high. And more than all of this, she was clearly deteriorating despite all the efforts of the team in care of that patient. So they called us for rescue therapy with VA. Considering the hemodynamic profile, we sent our mobile ECMO retrieval team, and she was implanted by with a peripheral VA ECMO. Then she arrived in our ICU. You have here the echocardiographic studies of that patient. On the upper part of the slide, it was before implantation, so severe tachycardia and biventricular severe dysfunction. And on the lower part of the slide, when she arrived in our ICU equipped with a VA. And you can see that hopefully we had a VA because her heart had completely stopped its mechanical activity. She had no opening of the aortic valve. And in fact, her heart had stopped also its electrical activity. She arrived in asystolia. So we are quite surprised because at that time we had no experience of those patients with a complete abolishment of their myocardial function and in asystolia. But the ECMO was running well. Usually when the patients are dying on ECMO, you have an extremely severe vascular leakage, you have coagulation disorders, you need to put a lot of fluids and blood products. It was not the case. The ECMO was running well. And so we decided to wait a little bit more to see what would happen. And what happened is this: she recovered quickly. After several hours, we could see ECG KG signal occurring again, and then her heart restarted to function. And here we are talking about that patient. We had this extremely severe sepsis-induced cardiogenic shock that was rescued with VA. And again, with a complete abolishment of myocardial function. But who finally recovered quickly. So again, we are here 4 days after VECMO implantation, and she was recovering clearly enough to remove the VA with an aortic VTI of 18 centimeters during a standard winning trial, and the left ventricular ejection fraction that was in fact quite acceptable. And then her heart completely normalized during the follow-up. She had to stay with us for a while due to renal insufficiency to recover from all the organ dysfunctions. But finally, she could come back home and return to normal life. And we have some news from time to time. So finally, with this cohort, we are dealing with a pathology with a high potential of recovery for the heart. And accordingly, we had quite low duration for our ECMO. It was 6 days mainly for survivors. Of course, dealing with those extremely severe patients, we had quite prolonged mechanical ventilation duration, renal replacement therapy. A lot of patients were transfused. And one important thing, dealing with those refractory septic shocks, we are dealing with a lot of pneumococcemia, of meningococcemia, with patients with extremely severe DIC. And so, not surprisingly, we had a quite high rate of major amputation in those patients. 1 over 5 patients surviving. Hopefully, for the large majority of those patients who had an amputation, it was restricted to some fingers or some part of the foot, but we had more important amputations, unfortunately, for some of those patients. But you will see that finally, this cohort is reporting a good quality of life. We had, of course, a lot of complications also due to the ECMO system. It's always the case, and that's why ECMO is used at that time as a rescue therapy, one patient over 2, mostly insertion site hemorrhages, some infections, some amputations also due to the ECMO system. And finally, we had a quite prolonged stay for those patients. But looking at the quality of life, we are here 1 year after the episode for those sepsis-induced cardiogenic shock patients in red compared to the general French population in blue. And you have the physical aspects of their quality of life using SF-36 scores. You can see, and mental status, and you can see that they were complaining about physical impairments compared to the general population, but they were reporting extremely high and preserved mental and social status. And both indices were comparable to those reported by patients recovering from myocardial infarction and clearly better than patients under hemodialysis program. So finally, a good quality of life. So this is where we are, and you have here the last publication regarding this topic, a nice meta-analysis published by McLaren's group. They summarized all the studies dealing with that topic of refractory septic shock. And clearly what appears is that how crucial is the left ventricular ejection fraction for the results. And the results were good in cohorts dealing with patients with severe myocardial dysfunction. And on the contrary, results were really disappointing in patients with a preserved left ventricular ejection fraction and mostly vasoplasia. Is the left ventricular ejection fraction the right parameters to decide to go to VA? Probably not, because as you know, left ventricular ejection fraction is affected by several parameters: the volemia, the level of catecholamine, the level of systemic vascular resistances, And you have an example of that here. It's also an old cohort during the 80s. All the patients here have preserved cardiac index, but you can see that non-survivors have a better left ventricular ejection fraction than survivors, which is quite unexpected. In fact, if you look at systemic vascular resistances, those non-survivors patients in black have higher vasoplasia and lower systemic vascular resistances. And this is probably which explains the difference in left ventricular ejection fraction. Probably those patients had the same or more or less the same myocardial function, but due to the differences in systemic vascular resistances, finally they had differences in left ventricular ejection fraction. So this is probably the cardiac index, which is the most appropriate parameter to evaluate the level of sepsis-induced cardiogenic shock. So according to those data, we can say that ECMO in that study was associated with a drastic reversal of sepsis-induced cardiogenic shock prognosis, associated with 60% long-time survival, complete myocardial recovery, good quality of life indexes. On the contrary, we can say that at that time, data are not supporting the use of VA-ECMO during refractory vasoplasia. And this is where we are now. I think we have enough data to say that VA-ECMO can be an efficient salvage therapy during refractory sepsis-induced cardiogenic shock. So when you have patients with a left ventricular ejection fraction below 35 and a cardiac index below 3, deteriorating despite maximal treatment, I think we have enough rationale to use VA as a rescue therapy, but there are lots of questions remaining. One of these is, should we go to an earlier implantation? What would be the parameters for that? I think the right parameters would be those retained for the defining sepsis-induced cardiogenic shock in the control group of our Lancet collaborative work, meaning severe myocardial dysfunction combined with hyperlactatemia and significant catecholamines received. We had, again, more than 75% mortality for those patients. But doing that, we will get out of a true salvage therapy, and I think we need a randomized trial to move forward with this earlier implantation. And I think this is a big question, and this randomized trial would have other advantages. Clearly, we have the feeling that VA-ECMO is underused in those patients. We had some confusing times due to the pandemics, of course, but even after the pandemics, now the situation is stabilized, and we have less patients than we would have expected after the Lancet study. In fact, it did not increase that much compared to before the publication. And there are probably two reasons for that. The first one is that when you look at the care of those patients, you see that, in fact, a lot of those patients do not receive a close monitoring of their hemodynamic status. And as their hemodynamic status can change from 1 hour to the other, probably some of patients moving to this particular hemodynamic profile are missed. And the second reason is that here in France, I don't know if it's the case in your countries, and we could discuss about that, but physicians are still quite reluctant to go to VA-ECMO in those patients because they are not used to the technique, to the mobile ECMO retrieval teams and whatever. So I think increasing the level of evidence in that topic may help to convince those physicians and to highlight the crucial importance to have a close monitoring of the hemodynamic status of severe septic shock patients, because we have an efficient treatment in those developing sepsis-induced cardiogenic shock. So this will be a big issue for the next few years, and I think we will have interesting discussions about that in the context of ELSO. So thank you very much for this invitation, and I will be very happy to discuss about this topic and answer your questions.
Nicolas, thank you very much for your fascinating feedback, for your fascinating presentation, and thank you to all of our participants to coming back in after the short technical issue that we experienced. Nicolas, I think you made it very clear that there's a subgroup of septic patients that qualify for this likely life-saving intervention. When we look at the baseline variables of the cohorts that you have shown, I think the majority of us will agree that these patients are virtually dying at the time they receive the cannula. As the questions are coming in, I have a couple of questions myself with respect to the management and also with respect to the complications. Now, the first question would be about oxygenation, because in your cohort that you published in the Lancet, 78% of the patients had pneumonia. And given the likelihood that with the femoral cannulation, which was used in all but 2 of those patients, I understand the likelihood that you run into oxygenation issues with an already impaired lung function, to me, seems a natural concern. How does it play out in practice? It doesn't seem that this seems to be a limiting factor in your patients. Why is that so?
It's a very good question. And in fact, it's a particular issue for those patients because, again, we are dealing with a lot of extremely severe pneumonias here. When the heart of the patient is not functioning, it's not really an issue because all the oxygenation is taken in charge by the ECMO system. But those patients are recovering very quickly and very frankly, and they are particularly at risk for developing severe Harlequin syndrome, and that was the case in that cohort. We had, I don't remember exactly the proportion, but it was around 1/3 of the patients who necessitated an early switch from VA to VV due to refractory Harlequin syndrome. And this has to be anticipated also because using VV, you will need to use higher blood flows than VA. So this is probably important for those patients to respect a quite large drainage cannula, 25, 27 French at least. Anticipating that you may need to switch quickly to VV and to reach higher blood flows.
We definitely want to look for Harlequin syndrome with our standard measures. That seems to be really important. I also was surprised to see that you reported only in one of those patients pulmonary edema. If I think about patients with cardiogenic shock due to other reasons, my experience is that this should be much more. Could you comment on that, and did you have to consider something? Some measures to overcome that in any of those patients, also previous patients that you had treated?
Yeah, it's a very good question also, Peter, but in fact, it's complicated because we had, again, a lot of pneumonia here. So probably the patient for a while had some lesions of pulmonary edema intricated with the pneumonia. But what we can say is that as they recovered quickly and frankly, they were able to clear spontaneously this part of pulmonary edema, and we did not need to use other strategies to unload the left ventricle, like intra-aortic balloon pump or Impella systems or whatever. All those patients were managed without any venting of the left ventricle.
So this was also one of the questions of our participants, that if you see an indication or have experience that you had, for example, to in place a balloon pump, but that doesn't seem to be the case. Now, with respect to the general management, do we routinely administer hydrocortisone to those patients?
Yeah, of course, they were receiving the large majority of them, almost all of them were receiving corticosteroids, but hydrocortisone.
Mm-hmm. Okay.
Hydrocortisone.
I think that's what's also striking in your patients is that they have a medium duration of ECMO of 6 days, but when you look at the ICU length of stay, that's much longer. So even they're off ECMO, they seem to have quite some issues. Is that the recovery of the general multi-organ dysfunction?
Yeah, clearly. Again, we were dealing with end-stage rescue therapy. So at the time of ECMO implantation, they had severe multiple organ failure, and they, of course, needed some time to recover from these failures. Renal failure, we had to use renal replacement therapy for a large part of those patients, mechanical ventilation and everything. So it took time, of course.
Okay. There's a comment by Graham McLaren who's in the chat who states that they often have to shift from VA to VVA, or sometimes they also start on VVA. You're much more into the sepsis-specific community of ECMO. Is that something that's being discussed among your expert people, apart from your singular experience where you say you don't really see that you need it?
Yeah, in fact, we had to switch. Again, we had to switch from VA to VV in about 1/3 of the patient, and for some of them, we had to switch from VA to VAV and then to VV when they had an intermediary recovery of the heart, not allowing to remove the VA, but enough to create a severe Harlequin syndrome.
Okay, I think that's a very important clarification, that if you consider this therapy, you need to be able and you need to be prepared that this is something that you might have to do next. I thank you for this. Now, you mentioned the rather high rate of major amputations, and since you listed some of those amputations in the category of ECMO complications, I understand that you also lost some legs after femoral amputation that you would attribute to the ECMO itself, right? Do you routinely use antegrade reperfusion cannula in these patients?
Yeah, in La Pitié, and for that cohort, in fact, it was a multi-center cohort, so I don't remember exactly what were the strategy for the other centers. In La Pitié, what we were doing is an antegrade reperfusion systematically inserted, consisting in a 7-French catheter. And I can't remember what the others were doing, but this is something we can recover. Yeah. Okay.
There's one question with quite some rationale. We may expect a rapid reversal of ventricular function in the case of correction of the acid-base deficit. So one of our participants asks, why not go to VV ECMO first and try to correct at least the respiratory part of acidosis, if that is an issue in the patient, wait what happens, and then keep the VA part of the extracorporeal circulation as a second step?
I think we are really dealing with in fact, a cardiogenic shock status. It's a sepsis-induced cardiogenic shock, but finally, patients are managed exactly like cardiogenic shock patients. So I think the major problem we have with those patients is restoring cardiac index, and I don't think VV would be helpful for that. I don't think we have data to answer the question, because I don't think we have that much a VV ECMO inserted in that context of severe reduced cardiac index, but clearly VV ECMO is not the answer for those patients. It's VA, because we are really dealing with the cardiogenic shock, in fact.
Okay. There are a couple of questions with respect to contraindications or patients that you would not consider as an age or comorbidity. I think what's striking in your cohort is that you have a very low Carson comorbidity index. So it seems like you are really screening patients. Could you make a comment on which patients you would not consider in your daily practice?
It's a very good question also, and an important issue. I would say that we are dealing with salvage therapy, meaning as soon as we are thinking about using VA for those patients, it's because we are thinking the patient is about to die if we continue like this, meaning that we don't have a clear contraindication. The idea is to see what is reasonable or not, but mostly regarding ethical considerations and the level of healthcare consumptions. I would say that as we have a clear recovery of the heart of those patients, you could see that none of those patients had to be switched to long-term assist device or to heart transplantation. It was really on-off. Some of them died from multiple organ failure. The others recovered completely. So I think we can push a little bit the indications compared to, for example, an acute MI cardiogenic shock with a low potential of recovery. So I think in terms of age, in terms of comorbidities, we can deal with more severe patients than for other indications without any potential of recovery. I would say that, and then it's a case-by-case decision.
Okay. The next question would be about the topic that you have already mentioned, the timing of the introduction. I mean, if we look at the rather short ECMO runtime in those patients who did not survive in your cohort, you could question whether they may be connected too late, right?
Yeah.
And when you mention that in a randomized controlled trial, it's also the question if you wouldn't want to start early, that would also have the risk that if you treat patients who are not as sick, the treatment effect also may not be so high. So if you wouldn't exclude very many patients, there would be a risk that that's a negative trial, right? So the timing issue seems to be very crucial. And one of our participants asked, because she reports that in their center, she feels like patients are coming too late. When would you consider a patient to be too late for this intervention?
Too late. Too late is complicated also. We are dealing with rescue therapy, so it's extremely complicated to answer this question because it's really a case-by-case decision depending on the comorbidities, depending on the level of severity, but globally, I would say that implantation under CPR for that indication is not a good thing. We have data showing it's not working. So at least it's a cutoff. Then as soon as you have an extremely severe condition with pH below 7, lactatemia above 15, and very high doses of catecholamines, this is the time you can say that probably it's not reasonable to do the therapy, but even in a young patient, it can be debated, in fact. I don't know what is your opinion, Peter, but it's a complicated story dealing with those rescue therapy.
Absolutely. I think, that's not only a fact for those septic patients. That's something we have considered in initiating ECLS and other indications as well, right? Another question would be on how to deal with the anticoagulation in these likely very frail patients with, as you have mentioned, thrombocytopenia and DIC. What's your practice with concern to that?
Usually with those patients, it's easy because they are suffering from severe DIC and they are bleeding a lot at the beginning. So usually at the beginning, you stop completely all the anticoagulation and you mostly use blood products to restore an adequate coagulation system. Then as soon as the situation is stabilizing, it's always the same with VA. We use low doses of unfractionated heparin with a target APTT at 1.5.
Mm-hmm. Do you routinely monitor your patients for post-ECMO thrombosis after decannulation?
Yeah.
And
yeah.
do you have a feeling that this is any different in septic patients than in other patients?
I couldn't say for septic patients, but globally we have about 1/3 of the patient exhibiting significant thrombosis of the IVC, and for them we maintain anticoagulation.
Okay, so no real hints that might be any different. Okay, so what's next? You mentioned the RCT. How far are we with that? Can we expect anything like that to happen in short time? We are very curious about that, Nicolas.
I hope this is really something I would like to set up. But I think we need really a collaborative discussion about this trial, probably in the setting of the ECMONet. And we need, of course, fundings. And at that time, this is not set. So there is a lot of work ahead for that randomized trial. But I think we need this randomized trial for this topic. I think it will be important to move forward.
Okay. So are there any things that you yourself would like to add to the discussion? Because I think the hour is coming to an end, and I have screened the questions of our audience, and I think this is about what they wanted to know, and then I think it's been a very fruitful and informative discussion. Is there anything else, Nicolas, you would like to say?
Nothing on the topic. I would like to thank you and the audience for this moment, and the audience for the questions. And I hope we will have further discussion on that topic in the next months, years. Thank you so much.
Absolutely, Nicolas. So once again, I would like to thank you for your excellent presentation and for the outlook into the future, that this may become even a more evidence-based method that can be applied more often by centers who may be reluctant at this stage for whatever reason ever. I would like to thank the audience and remind all of you to sign up for the upcoming EuroELSO annual meeting in Lisbon, April 26 to 29. Nicolas, I suppose you will be there as well. And so there will be time for more discussion, time for learning and sharing our experiences. Please come. And for now, I would like to thank all of you. Wait for the announcement of our next webinar, which will be very soon. And please don't forget that you're only on the safe side if your venous line is blueberry and your arterial line is cherryberry. With that, thank you very much for today, and goodbye.